Hello and welcome to today's webinar, Safely Navigating Healthcare and COVID with Your Living Will, presented by Dr. Ferdinando Mirarchi, CEO and CMO of MIDEO Health and founder of MIDEO, My Informed Decision on Video. My name is Jeff Stauffer, Community Relations Director with Elville and Associates, and I'll be moderating today's event. So welcome to those that are new to our educational webinar series and also to those that are frequent attendees. As always, if and when you have questions, please note them in the questions panel on the right-hand portion of your screen, and we will take time throughout to address them. Your questions really help the presentation and add value. They help others learn, so don't be shy in posing your questions at any time. You receive the presentation from email from me to take notes on if you wish. The presentation is also available in the section marked handouts in the panel on your screen to download at this time. For our professionals on today's webinar, for CFPs, CPAs, and others, welcome as well. You may receive 1.0 continuing education hours for attending. And per my attendance records requirements, please email me your ID number as soon as possible if I don't have it, so I can submit your CE hours for approval first thing tomorrow morning. Everyone will also receive a post-webinar feedback email right after the presentation, and we ask that you please take just a couple minutes to fill out this very brief survey to offer us your feedback about the presentation. So I'd also like to offer Dr. Mirarchi a very proper introduction before we get started. Dr. Ferdinando Mirarchi is the Chief Executive Officer and Chief Medical Officer of the United States Acute Care Solutions MIDEO LLC. He has recently been appointed as the Chairman of the National Palliative Care Committee for USACS. Dr. Mirarchi is the Principal Investigator of the Triad Research Series, Triad standing for the Realistic Interpretation of Advanced Directives. The results of his Triad research have been featured in the New York Times, Washington Post, Boston Herald, and many more nationally syndicated outlets. The Triad research has confirmed there is a new nationwide and global patient safety risk related to confusion surrounding living wills, DNR, and post orders. His Triad research has also set the foundation for the development and utilization of a state-of-the-art evidence-based patient safety solution called MIDEO, short for My Informed Decision on Video. MIDEO has been structured to be both a video advanced directive and portable physician's medical order that is prescriptive, clarifies existing documents, and retrievable in seconds. Dr. Mirarchi serves as a reviewer for peer-reviewed scientific journals such as Chest and JAGS, and is an editorial board member for Patient Safety magazine. He is the author of Understanding Your Living Will, What You Need to Know Before a Medical Emergency, and holds many other national positions in the medical field. So Dr. Mirarchi, it's great to see you again. Thank you so much for being here. We know you're very busy, and we appreciate your time in this presentation today. And I'll turn it over to you.
Well, thank you, Jeff, and thank you everybody at Elville for finding value in this talk, especially in these times, and especially in that typically these types of documents or orders are created by firms. So really, hats off to you guys for wanting to make sure that your clients are navigating safely through the healthcare system and so on. I hope everybody can see my screen okay. I'm going to get rid of a couple windows on my screen so they're not blocking my slides. But if you do have questions, please feel free to just respond in the chat with the questions. I'll try and take a few breaks in between the presentations so that if there's something I think we can maybe engage the audience on and ask some questions, we'll do that. All right, and we'll get started. So the biggest piece of what we're going to talk about here is safety and safely navigating this very, 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 very complex healthcare system. And I'm a physician, and I will tell you myself, I have difficulties navigating this system at times with years of administrative experience. So to the lay person who has to go through this system, I can only imagine some of the questions that may come through your mind. So as I present, most of everything that I have to disclose, Jeff actually just talked about here in my introduction. The only thing I'd like to say is that I am the founder of MIDEO. I was the owner of the software platform that is now owned by US Acute Care Solutions. US Acute Care Solutions is a physician-owned entity. It's probably one of the largest nationwide acute care practices in the country, and this is where I felt this technology needed to land. It needed to be with providers and physicians rather than just payers, because I wanted to make sure that they had the patient's interest at heart. So with that, I'll get started. And I think I like to start this off very commonly with this little cartoon of Snoopy and Charlie Brown. And it's one of thought, right? You know, Charlie Brown's thinking, you know, someday we're all going to die, Snoopy. And then Snoopy reverts back very quickly and says, true, but on the other days that we're going to live. So it's very important here that we talk about this, because what I look to do in our practice and with MIDEO is to make sure that we keep you safe and have you thrive through your life, your retirement, because many people will have very projected longevities, and there are other people out there that don't have the same intentions that maybe some genuine physicians do when it comes to looking at expense costs and medical expense ratios and so on. So we want to make sure that we put things in place to actually give you a say, give you a voice in your care, give you a say in how things done. And we never want it to be paternalistically provided to you, because then you lose all control. So I want to say and share this, and this is probably something that many of you have. I got to try and get a window out of the way here, but these are the 5 most important estate planning documents that are commonly talked about. And what they are is a last will and testament, different from a living will, a living trust, different from a living will, a durable power of attorney, a healthcare power of attorney, and a living will. So that's the 5 most important things. And 2 of those are very concerning in what we do in clinical medicine, because they're not very understood, specifically the living will, and then to a second degree, the healthcare power of attorney, because there are times that people believe just because they are appointed that they have control over a patient or a parent, when in reality they don't. And a lot of times we spend time trying to clarify that the patient still has powers until they lose capacity. Same thing with living will documents. And we're going to kind of talk over some things with the living will. And I don't mean to scare anybody with respect to this, but I do want to make sure that I raise the awareness that there are a lot of things happening on the patient safety front with these documents and orders when you come into a healthcare system. So I figure the best thing to do is show you what happens. And this is a gentleman, and we'll call him Joe for now, and he's in his 60s. And he's doing very well in life, and he has chest pain one day. And he goes to a local emergency room. And in that local emergency room, they do an EKG. And if you take a look at my mouse pointer here, right here is a very, very, very big heart attack. We call that a widowmaker. And about 30% of the time, that will make people like Joe or females just drop instantaneously into something called VFib, cardiac arrest. Very scary situation, but it has therapies, especially if they're witnessed. So what happens is Joe has one of those 5 most important documents in his estate plan, a living will. And very commonly, the living will has all the boxes checked that say, I do not want mechanical ventilation, I don't want cardiac resuscitation, feeding tubes, and so on. And that's very common because of how it's been explained to them. But when they bring them into healthcare systems, there's a different understanding of these documents, especially when there's not tons of time or tons of familiarity with the document to make sure that people read it appropriately. And that's one thing I'm going to assure you, that these documents are not read appropriately to make sure that people or the providers actually understand what they're supposed to do. So now Joe has this document. Joe has this cardiac condition happening called a heart attack. And what happens next is what, and I don't mean to be crass here, but these are our holy crap moments in emergency medicine. This squiggly line is something called ventricular fibrillation. This is the cardiac arrest. This is what you see on television. This is what needs to be very, very, very quickly shocked to save someone's life. And honestly, if it's witnessed and we can provide the electrical therapies, people wake up from this like that, and then we send them to the cath lab and they get their arteries opened and they go home. But what ends up happening is, in that instance where everything is hitting the fan, so to speak, you have somebody in cardiac arrest, someone critically ill in cardiac arrest, and you have this document that is perceivingly telling the providers to not treat. So the reality of what then happens for someone like Joe is we get it wrong. We get it wrong for Joe no matter what side of the fence we're sitting on. Now, these are some triad studies early on. The first one is a triad 2 study in a pre-hospital setting, meaning in the back of an ambulance and so on. And about 36% of the time, a patient like Joe would get shocked in this same clinical scenario. That's 36% of the time we would save his life. That's a big no, that's a big error here as far as the amount of people who would not have their life saved in this situation. in our Triad 3 study, which was a nationwide study of physicians across the country at some of the biggest medical centers across the country, it was basically a coin toss on who would shock Joe and save his life versus just letting him die. Now, mind you, there's an error on both sides of the fence here. Joe may not wanted to live with his conditions because we don't really know at this point in time, but maybe he did. So either way, we're screwing up here on both sides of the equation because we don't have enough information. We don't know who Joe is. We don't have his medical history. We have providers that are unfamiliar with these types of documents. So from all of these issues happening, the American College of Emergency Physicians put out policy statements and essentially said that advance directives are good. They're needed, they're well intended, but they're often vague. And because of that, physicians may in good faith initiate or withhold treatments that are contrary to the patient's wishes. So that's a red flag right there. That means that we're providing care or not providing care that a patient wants. So we're either over resuscitating patients and saving a life that didn't want to be saved, or we're under resuscitating patients and not providing enough care to save their life. And it's all because of these documents. And it's because of how they're framed, how they're worded, and the lack of education and training inside of the healthcare system. So I figured this would be a really good time to kind of explain a few things about living wills, do not resuscitate orders, post orders, most orders in your state of Maryland, and then maybe even MIDEO to a degree. So, but when we talk about living will documents, living wills are supposed to be expressions of a patient's preferences regarding end-of-life healthcare decisions when they can't make that decision for themselves and have entered a terminal or end-stage condition or a persistent state of unconsciousness. Living wills are not to be interpreted by anyone other than physicians and in some states advanced practice providers. However, when healthcare providers such as EMS providers and nurses come across them, they often express their opinion as far as what they believe that living will is. So it's not uncommon for us to hear, hey, that patient has a DNR order because of their interpretation of that living will. And the reality of it is they're not a DNR at that point in time. Now, living wills are not automatic do not resuscitate orders, but I will tell you the research shows about 80% of the time that living wills get equated with automatic do not resuscitate orders because of healthcare unfamiliarity of how to apply these documents. So very concerning, but what I really want to convey to everyone is terms as far as living will documents. There's a term called effective, meaning the document's valid and legal. You went and saw someone at Elville, they made you a living will and a healthcare power of attorney document. Those are now effective documents, but they're not triggered. Okay, triggered or enacted or activated is one in which the conditions of the document then bring that document alive and make it so that we should just follow it. So when we come across living wills, we really shouldn't do anything other than have a conversation with a patient to set a plan as far as goals to make sure that we're treating them appropriately. We shouldn't be following the directions of the living will just because the living will is present. That's a no-no. So really important to understand those two pieces there, because we get patients as well or families as well that come up to us and say, well, they have a living will, they don't want treated. Well, that's not true, because they might only be there in the hospital for urinary tract infection, and at which point in time we would still want to treat it depending on the conversation that we have with the patient or the patient's appointed healthcare agent. So the next type of thing I think that would be really good to educate everybody on, especially in that we're talking here during National Healthcare Decisions Day week, is do not resuscitate orders, because there's a living will, there's do not resuscitate orders, there's out of hospital do not resuscitate orders, and then again the post orders. So a do not resuscitate order, many commonly believe they understand, and that really is an order. It's a medical order, and it's an immediately actionable medical order that has a trigger, and that trigger is when you go into cardiac arrest. And in some states it's cardiac arrest or cardiopulmonary arrest, or it can be the combination of the two. So each state's different, and it really comes down to the medical providers to really take the time to understand what the differences are in the states, because patients do cross state lines as well. And we really have to make sure that we're on the same page of the patient or the patient's appointed healthcare agent when we're trying to make decisions. Now, do not resuscitate orders are not really to be addressing the withdrawal of care or withholding of care other than CPR. There's other terms that we use for that. And when I say CPR, we mean chest compressions. We don't mean anything else, but there are a lot of policy statements that get built upon bad information and then apply that term DNR to mean a patient wouldn't want other forms of treatment. That is incorrect. What is correct is that if a patient is found with no pulse or not breathing, that is the time that a do not resuscitate order comes into play. So with that, I figured the next thing we would do is talk about the out of hospital do not resuscitate order, because that's a bit different. Now, the out of hospital do not resuscitate order, again, is another medical order. And this time it directs the care and treatment when in cardiac arrest, but also critically ill. And it's to not provide anything aggressive with any form of resuscitation. So this is the order that can be followed by EMS providers. And this is sometimes where we lead to misunderstandings of what terms mean, because in the pre-hospital setting, the out of hospital do not resuscitate order means something different than the in-hospital do not resuscitate order, as well as any advanced directives. So all of these terms, unfortunately, get used interchangeably, and they get misunderstood by all the medical teams. And it takes time to really clarify what the intentions are to make sure that we keep you safe as you navigate through the healthcare system. So the next thing I want to talk about, and then maybe we'll take a break and just see if there's any questions. But the next thing I want to talk about is something called the pulse order. And in your state of Maryland, it's called the MOLST order. And this is important because this is what, well, at one point in time was a physician's order. Now it's been dubbed a portable order for life-sustaining treatment. And it defines care basically in these forms of boxes. So box A is care in cardiac arrest. Box B is care outside of cardiac arrest. C is your choice on antibiotics, and then D, E, and F are basically some other confirmatory pieces as far as who you talk to, and then signatures and so on. So there's been a national push on these orders, and the national push tries to make it so that anyone can really follow them after they're created. And I think that that's a no-no, because a number of people really need to have these forms checked and verified for accuracy. And in addition, a number of states are doing some things differently. Like in the state of Maryland, you get a MOLST order, which stands for a medical order for life-sustaining treatment. Now, if you got admitted to a hospital, got transferred to a skilled facility, you got transferred to another hospital, there is a process in the state of Maryland that mandates that one of these MOLST forms get made for you, which in some theory is good, but in other theories is bad, especially if the form gets created incorrectly, which it does, and we'll talk about that in a little bit. But we want to make sure that the right people are following these forms and the right people are creating these forms so that we keep you safe, again, as you navigate through this healthcare system. Because a post order is not another form of do not resuscitate orders, although it can contain do not resuscitate orders. It's not a living will, although people can create it based off of the statements made in a living will. And it's not an order not to treat, but oftentimes will get misunderstood as an order not to treat. And some things I want to point out here on the form are very concerning, and I've tried to make this aware to many of the people on the national level as well with this, is that when you first look at the form, I'm going to back it up a second, but when you first look at the form, there is some text and fine print throughout the form. So I'm going to blow up the first box. The first box says, first follow these orders, then contact a physician, certified nurse practitioner, or a physician assistant. And the order set has been, created based on the person's medical condition and with dignity and respect. Now, I will tell you that the most appropriate thing to do when we ever come across these forms is confirm them or to verify them for accuracy, because there's high levels of discordance on how these forms are created. But in the theory and in policy, they want people to follow these forms after they're made and then ask questions later. I think that's always been a no-no in clinical practice. We always want to check and verify first, make sure that we're providing the right levels of care. The second piece of fine print that I want to bring up, and you may be able to see it, you may be able not to see it, but it's very small and it's in that first box, box A, and I'm going to blow it up for you. But it says essentially here, when not in cardiac arrest, please follow orders B, C, and D. Now, I will tell you that when we have emergency situations happening, or we're just pressured because we have to get to the next patient or so on, people will often just glance at these forms. And when they glance at the form, they essentially will see that either the first box saying CPR, attempt resuscitation, or the second box saying do not resuscitate, allow natural death, and then make their decisions on what they're going to do based off of that quick assumption, not really reading through to make sure that they understand that this was only for a cardiac arrest situation only. So before I go off here, I just want to take a minute and Jeff, if you can tell me if there's any particular questions that came through so far that you think we need to address, or we can move on. But I just want to take a minute here to pause because we're going to talk about some other things with post orders and advanced directives.
Thanks, Dr. Mirarchi. No questions as of yet. However, I want to mention that we're familiar with the MOLST worksheet at our office. Is that something that you would consider helpful at all for a MOLST, or does that continue to yield, confusion and issues with these forms being filled out correctly?
So it really comes down to when it's the appropriate time of a conversation and how the conversation is framed and how those forms get completed, quite frankly. Because you could have different conversations, right? And different people creating them that may not have the same level of competency in creating the form. So it all depends on how much time and training the firm essentially puts into training the individuals creating the form or actually guiding the conversation of the form creation with the clients.
Sure, and yeah, we don't advise clients on how to fill the form out. We simply try to provide the information and encourage them to speak with their physician or healthcare provider about it further.
So that's good though. I mean, and one of the things we'll talk about too, as well, as far as in our clinical practices with MIDEO, I mean, we create those forms for people as well as patients themselves, just to make sure that they're done correctly. Because the worst thing you want to ever have happen is a MOLST get created incorrectly, like poorly formatted, and result in discordant care, and have that order set still remain because they don't nullify as soon as they leave the hospital. We've gotten really crafty with electronic medical records to actually bring those orders forward for the next clinical visit, which that incorrectly made form then on the first visit could then come about and impact the care and treatment on the second, third, and fourth visits moving forward if it's not recognized. Okay, so I'm going to move on and we'll talk about just some pitfalls of the advanced directives and the post forms, especially in post-acute settings as well. Now, regardless of this post-acute setting, we know there's issues with the living wills. We know there's issues with post orders, MOLST orders, do not resuscitate orders. And a lot of them stem from the living will itself because the living will gets misinterpreted as do not resuscitate orders about 80% of the time. And that number goes up if you're a nurse. It goes higher if you're a pre-hospital provider. And I think part of that issue is just everyone's not involved in the conversations to see what happens when we come across living wills and make decisions in their care. They just see the final outcome. For example, walking out of an ICU room after we had a conversation, the nurse wasn't involved in the conversation, but they then see us write a do not resuscitate order when we review the living will. And again, it's just because of the context of the conversation, they weren't fully involved in to see what actually happened. Now, we do know that post and MOLST forms actually have frequent errors in order creation as well as the interpretation. And then we speak of something called discordance, okay? And discordance means that we didn't get it right. It's a nice way to say we didn't get it right. And the post orders themselves have about a 44% discordant rate. And in one study had to be rescinded about 38% of the time. And in that same study, about 25% of the time, the patients or the appointed agents weren't even aware that the order existed, which then leads to a lot of anger, feelings being hurt, and then subsequent lawsuits. Now, for example, this lawsuit here was a family that sued a hospital and won $1 million for a post form that was written without their consent. And that's what I speak to the issue of, that you always want, when you come across these, providers should always want to check and verify with a patient or a family prior to either not providing certain types of care or providing certain types of care that we think the patient wouldn't want. So when we look further into the skilled nursing facilities as well as rehabs, post discordance gets even higher. Simply just off of the form being created itself, it's about 56% of the time. If it's comfort-based, there's usually a little bit less discordance because that's maybe a frail elderly person that everyone's trying to focus on comfort for. but still the discordance is 32%, which is still pretty high. And what we know is that transitions occur, confusions happen and miscommunications happen in transitions or transfers. And it's a really high rate. It happens about 80% of the time. So when you have bad pieces of information getting communicated poorly, that rate of error and harm to the patient goes even higher. So when we look further into everything that's been done with this, okay, and taking a look at what's good to use or what's not good to use, we took a look at everything that's been done with POLST and MOLST and so on, and really come to find some things that it really is unclear if this is actually a safe process. Like, for example, the MOLST in the state of Maryland, if it's a safe process, it improves the delivery of care. But there's moderate strength of evidence that says, you know what, it can reduce treatment intensity with serious illness, which is good for certain patients. If you're a patient who's not doing well and you're towards that terminal scope of care and you don't want to receive these forms of care and treatment, it may have some benefit. But it comes as a trade-off that there's actually moderate risk of POLST or MOLST causing discording care or errors in the medical care, which then comes to the point of figuring out what happens next. So over time, doctors have always been comfortable, or not comfortable, because no one's ever comfortable, but doctors have always been accustomed to being sued for wrongful death or harm type litigation. We've never been comfortable with the idea of being sued for saving a patient's life, and that is actually happening today. And this article here is actually an article from the New York Times that was put together by Paula Spahn, that essentially families were upset because we saved mom or dad's life. And the reason for that is, one, someone maybe had just made a statement that, hey, they didn't follow the living will, or two, we're coming to find that patients' estates or the family estates are being evaporated because of the care that would then come to follow because of the care we provided. So it's become a true reality now that we can actually induce harm to families regardless of the patient's outcome, but harm to the families because of what we did as far as the care we provided. So, and in these types of situations, the estate would pay for uncovered costs. And we know this is expensive because, you know, the cost simply to Medicare is about 25% of spending in the last year of life. We know that nursing homes for even a basic one is about $120,000 a year, and assisted living is about $72,000 a year. Again, very basic. So this causes a lot of change for people's families. It causes people to have to resign from the workforce, change careers, go part-time, and again, resign just completely to help take care of a family member because these costs are just too exceedingly high. And if any of you do have time, I'd recommend reviewing that article in the New York Times just to see the comment section there as far as the amount of people that talked about the issue of wrongful prolongation of life and even wrongful death. And you'll see quite clearly that this has become a new nationwide issue. So this is a true risk that we say for aging Americans, because the silver tsunami is already here and is growing at a clip that Medicare and entities are just not sure what to do with. And that's the age over 65 population. We're already at 54 plus million. We're going to be at 81 million by 2040, and I will be one in that group, in that 81 million people by that time. And we know that 50% of aging Americans are going to find themselves in an ER in their last year of life. And what is very concerning is that 50% of them will have no one to speak with them when they're most vulnerable. I literally just had a patient in the office just prior to coming here to do this presentation that has no one to make a decision for her. So we're actually going to utilize MIDEO in that situation to essentially be able to have her provide her voice at a time that she would not be able to in the future. And with solutions like MIDEO, we can now do that. We can have patients represent themselves in the future when they are incapacitated to actually be able to speak on their own behalf. So one of the thought processes we've had was to collaborate with elder, estate law, wealth managers, financial planners. And there's a few reasons for this. And one is the whole patient safety approach that we're looking to do. We're looking to make sure we diminish errors, diminish lawsuits, improve the quality of care. And what we found is that of the people who actually work with people, clients, you often have their best interest. You have your client's interest in mind when you bring your client into the office. You're a trusted advisor for that particular client. You really want to keep your client safe. And we really think that we can help with that process with MIDEO, which is why we took the approach to go into the sector of estate, elder, and wealth managers to essentially partner to make sure that we can bring MIDEO to the people who would benefit from it. Plus, we also teach people how to navigate the questions when you come into the healthcare system. So how do you want treated in cardiac arrest? Do you have a living will? We prep our patients with statements to say and provide ID cards to actually answer those questions. But the grid here, or the graphic here, which essentially talks more so as far as how it's grown over the years. So in May of 2005 to May of 2020, we know that education is a big factor, because if you're educated, you typically will have access to estate, elder law, and wealth managers who put together estate plans for those individuals. And as your income grows, same thing, you have access, you start looking to plan more. And essentially, as you see the levels of income, you will see upper income levels versus lower income levels as far as who will actually create advanced care plans or estate plans, which typically will include the living will and healthcare power of attorney. So it just looks like a perfect fit for the type of relationship so that we can provide services to your clients to make sure that we can keep them safe. Now, this is what we call our life cycle. And this is the patient safety life cycle that we put together for MIDEO. And patients come in various phases. All too often, documents like living wills and even post orders are one and done, meaning they do it once, they don't think you have to address it again, and it stays with that patient forever. We're different. We look at this as far as getting upstream early to take care of patients while they're in wellness and early illness to prevent under resuscitations, because you took the effort to put the right forms in place, but us on the medical side don't always know how to understand those forms. So we want to make sure that we keep you safe in wellness and early illness with MIDEO to make sure you don't get under resuscitated, but put some provisions in place, God forbid, if you had some terminal event or something like that, that we could then, make sure that you're covered. As your life cycle then progresses into advanced illness and decisions for end of life care, we then look to create the right statement for the right level of care that you want to make sure that we customize the care, because every patient's different. A patient with heart failure may not want to get intubated. Another patient with heart failure may want to. A patient with cancer may not want to receive chemotherapy. Another patient with cancer may want to receive chemotherapy. You can't really do that with paper-based documents or digitized documents, but you can do it very well with video and MIDEO. And then as we progress forward to that decision for end of life or hospice care, our goal there is to prevent over resuscitation of you and prevent that harm. Because once a family and a patient have come to make that decision that they don't wish for aggressive care and treatment anymore, and for us to disregard that and provide aggressive care and treatment, we've really broken the trust cycle down, not to mention induced harm, and prevented a patient from naturally dying who just wanted to die naturally. So that brings us to our solution, MIDEO. And MIDEO stands for My Informed Decision on Video. It's an it's an electronic form of advanced directive. It is a clarifier of advanced directives, not to mention a video-based medical order such as a PULSE or a MOLST. Now, essentially what we do is we look for ways to make sure that the patients can speak on video about their healthcare choices so that everyone involved can quickly and easily understand, as well as confirm the choices in those videos. So you can see from a perspective that, the daughter who's taking care of a mom who might be critically ill doesn't have to feel guilt-ridden about making a decision. She could see her mom telling her the decision to make. And then we utilize QR codes, and I would invite everybody at this point in time, and I'll even pause for a minute, to take out your camera of your smartphone and scan the top QR code next to Mr. Gallagher under his face. And you'll be able to see a link pop up, and pop that link, and quickly, within 5 seconds or less, be able to see a statement that we've created on his behalf to essentially guide his care and treatment. And then the back of the cards, the lower ID card here, essentially is a QR code that would link to any medical order or documents that he may have. So we put this process together to make things portable, and to make sure that they're credible, and to make sure that they're retrievable anywhere in the world in 5 seconds or less. So Jeff, right there, I'm going to pause for a minute and just give people an opportunity to actually scan the QR codes and see how they actually play out. And if there's any questions in the chat, maybe before we move on, we can answer a question or two.
Yeah, sure. I think that's a great idea. No, we have a few questions asking, you set the stage very well. Your questions about, well, what is the solution to all these, issues that you're bringing up? And, I just said, just hang in there because we're getting to that point right now to talk about MIDEO.
Awesome.
So, I went through the process a while ago. Here's my MIDEO card right here. I have one in my wallet, and I also have one on my refrigerator. It's a very easy process, very straightforward. And, should something happen to me when I'm out and about or when I'm here at my house, there's an easy way for people to know that are trying to help me to know what my decisions are. So offers, me and my family peace of mind, knowing that I've got a MIDEO card. So.
And one thing I want to clarify, and that everybody who thinks about advanced directives or living wills and so on, they think it's all about death. And honestly, when you take a look at what has to be done here and the advocacy that needs to be done on the part of patients, our goal is to keep you alive, quite frankly. I mean, our goal is not to have you die prematurely. Now, there are entities out there that are training people to essentially have these conversations with patients that are older, or over 65, or high users of the system, to essentially get them more comfortable dying. And I don't disagree with getting people comfortable with dying, but just because we put the right forms in place doesn't mean you want to die tomorrow. In advanced directives typically get misinterpreted in that belief system, where with what we create with MIDEO, we can clarify everybody's advanced directive to make sure that people are resuscitated when it's appropriate to resuscitate them, so that they get that chance to live that quality of life that they want to live. So I think that's probably enough time that we let people try and scan the QR codes. You agree?
I would say so, yeah.
Right. We'll move on then.
And, I know we have some, just one thing I'll say, I know we have some of our client care program members on the webinar here today. This is a service that comes with your client care program membership here at Elville and Associates. It doesn't cost you anything. Elville and Associates pays for the entire setup of MIDEO for you. And so that's something that, again, comes with many benefits of client care membership. MIDEO is one of those benefits. So after the webinar today, along with the recent client care program event link that we just got created and edited, when I send that out, I will let you know how we can help you get in touch with Dr. Mirarchi's office and get you set up with your MIDEO at no cost to you.
That's fantastic. So I'm going to move on. And when we talk about solutions, I think someone had a question there. We run on the premise of 3 C's. And it's the 3 C's to really ensure client safety. And with MIDEO, what we look to do is provide clarity. Clarity that doctors and family will understand the patient's wishes. Comfort that the family needn't fret over these emotionally charged decisions, as well as confidence that they know their wishes are going to be honored. Because that's those 3 issues there are reasons why people don't pursue the whole process of advanced care planning or estate planning, because they're just unsure. But I can assure people that our goal here is to provide the right care at the right time for you, and to make sure that you have a say in your care, because that's something that we're missing more and more as society is further developing. People are trying to take your voice away. We want you to have it. We want you to have it back, because quite frankly, you prevent us from having medical errors occur, because then we know what you want, rather than taking what we call a guess or from a medical stranger off of a vague piece of paper and then hoping we made the right choice for you. So the goal for the future is when an emergency happens or when there's some conversation regarding care, that if you're like a guy like Joe who got totally buried in the healthcare system by documents and so on, when you have an emergency such as a heart attack that looks like this here, and if you follow my mouse circling this area, and you have a document like this, such as a living will, that when you have that critical moment, that we can pull something up like this and within 5 seconds or less, make a decision to treat you or to allow you to die naturally based off of your own intentions. And if we can do that, we'll revolutionize patient care and safety as far as these types of documents and so on. So I wanted to spend a minute and talk about how COVID changed things and have you kind of recollect what's happened over the past 3 years and where this could have easily provided help for your family or maybe yourself as you navigated this COVID climate. Because what we saw is we got very restrictive with COVID. We put restrictions on you seeing your loved one inside the hospital, setting up restrictions on how many people can come in. We started to ration care, especially with respect to ventilators and ICU beds. We got to the point where there was attempts to limit critical care or limit care in critical illness or even cardiac arrest if a document was present. Now that got pushed back in various states, but I can tell you that it actually occurred. There have been such crazy staffing deficiencies leading to overworked and uncaring healthcare providers that if they have the opportunity to not do something more for you, trust me, today is a completely different time than 5 and 10 years ago in healthcare, where people were overly looking to provide the right levels of care. Today, they're at such stress levels. If they can take a minute and decide they're not going to need to treat something, they're going to move in the direction of going to treat the person they need to treat. So we don't want to give anyone that opportunity with a poorly created advanced care plan or a poorly created directive. Additionally, there's more one-sided, and I mean heavy one-sided end-of-life discussions because we're trying to make sure we're rationing the resources because we don't have the number of staff beds we need to in the United States anymore because of the workforce shortage that happened with COVID. And quite honestly, the place where we would put patients in the long-term acute care settings, the skilled facilities and so on, those beds are not available anymore, again, because of what we've done. So a number of patients are going home with hospice because of a conversation that led to that, whereas other times they would have been basically either sent to a post-acute or they would have been sent home with different conversations in place. So COVID has done a number of different things, and I can tell you our office and our practice is available 24/7 for people in those situations. So as if they need real-time guidance, that we can help provide that real-time guidance. So what I want to talk about is a process, and the process for you, yourselves, or the process for clients. Our MIDEO process is a very high-touch, high-quality user experience. There's a do-it-yourself process for people who are young, healthy, and just require uncomplicated advanced directives, versus a guided physician or clinical experience for people that have comorbid conditions or require complicated advanced directives. Again, I've criticized this on the part of what's been done in the past. We're not one and done with you all. If you come into our practice, you're part of our practice. You get risk stratified. There's multiple clinical touch points throughout the year. There's multiple clinical touch points in the following year up until the point we see you again. And we will risk stratify you based on your medical consultation to make sure we know to bring you back every 6 months, every year, every 5 years to make sure that we're keeping good tabs on our patients. We've made it such that we're the only program in the nation that does quality assurance review. Any MIDEO that gets created is reviewed to make sure that what was created is appropriate and would be understood with minimal risk of discordance to your medical care. Additionally, we've created something that's portable, both nationally, internationally. It's available nationally and internationally. I have patients in Singapore, I have patients in Australia, I have patients in Italy, England, wherever, and they all work very quickly in 5 seconds or less. And that's what we want. We want to make sure that we provide your MIDEO, as well as any legal documents you have or any medical orders very quickly and put them in the hands of providers when they're trying to make treatment decisions for you. Because I can tell you from working in the trenches of emergency departments or along the years, trying to find a piece of paper as an advanced directive and a stack of chart notes that come across often, it was almost impossible ever to find that document at a time when the care was needed to be provided. So this is my last slide, and then I'll take the screen share down and answer more questions. But you obviously are here for a reason. You either value your own care or you value your client's care. Our goal with MIDEO and at the Institute and with US Acute Care Solutions is to make sure that clients and families are not at risk. They are at risk. We want to make sure they're not at risk and make sure that we can prevent risk to keep clients and patients safe. Now, even though I'm going to answer some questions, I left my personal information here. So here's my email address, here's my cell phone number. There's a QR code that's there that anyone can click on or scan and take a look at a 90-second explainer on what MIDEO is. But if you don't get your question asked today, I implore you to reach out. Send me an email, send me a text, send me a phone call. We will get your question answered. Jeff, are you still with me?
Yep, I am. Yes. Thank you so much, Dr. Mirarchi. This is something that we've been speaking to Dr. Mirarchi about for a few years at this point. We had him present to several of our financial advisors. We thought it was very important for him to share this information with them, and so we wanted to bring it to you today. And so please do reach out to Dr. Mirarchi if you have further questions, want to learn more, want to get your families and yourselves involved, and get yourself MIDEO and learn more. So Dr. Mirarchi, thank you very much. Now would be your time to get any questions into Dr. Mirarchi, and we have a couple here, looks like. And a good question from one of our client care program members. Can a MIDEO be created remotely? Good question.
Yes, so we actually have software platforms that are in Android, iOS, as far as Apple products, in addition to a web-based application. And then we provide the clinical consultation utilizing telemedicine. And in our telemedicine, you're in a completely encrypted background so that all your information is completely safe.
Okay. And one of our good clients, thank you very much. Definitely very thought-provoking. So we'll get any additional questions in here. I'll say that for today, as follow-up from me, I will send out a follow-up email afterwards. I'll send out the video from today if you want to share it with any family or friends or others that you think might be interested and feel this information be helpful to them. Again, for our CCP members on today's call and beyond, this is a service that comes with your membership, and I'll be sending out some further information as to how we can help you get connected with Dr. Mirarchi. As far as our webinar series goes, we've got a really busy week. Tomorrow we'll be talking about guardianship and the alternatives with Lindsay Moss at 10:30, and then on Thursday at 10 o'clock, the state of the real estate markets. That will be Thursday at 10 o'clock, and then Friday at 10 o'clock, estate planning and elder law essentials with Steve Elville. And then nothing on the weekend. I think we'll need a break after this week. And I'll also send out, I know you have the slides, but if you don't have them, I'll send them again, and I'll include Dr. Mirarchi's contact information again in my follow-up message. So we'll check for any final questions here. Okay, so question here, what about joint conversations with one's own personal physician and MIDEO? Okay, that's the question. What about joint conversations with one's own personal physician and MIDEO?
So if your physician wanted to be involved in our conversations or our consultation with you, we wouldn't be opposed to it. We actually look, part of our process and our fulfillment process is to make sure that everything we do is coordinated either with your law firm or with your physician. So our typical package is you get 2 ID cards from us, one that goes to you as the patient or client, one that goes to your appointed healthcare agent. You get a magnet for your refrigerator, just as Jeff mentioned, because we train paramedics to look on the sides of refrigerators for any advanced directive information. You get a sticker for your car that says that you have a MIDEO, and essentially that goes on your back window. So we cover many facets there. Additionally, what we do to coordinate your care is to make sure that we send your primary care doctor a letter that includes your MIDEO so that we can make sure it gets into your electronic record. We send a letter to your attorney firm to make sure that it becomes part of your estate plan. Additionally, we send letters to your medical records department of the hospital that you frequent to make sure that it gets into your record as well. And we've been very successful. Not to mention, we have hospital systems across the country that are now exploring with us through what we call API networks to make sure that we can upload directly to your chart. So yeah, we are definitely open to communications as far as your primary care doctors.
I heard somewhere about MIDEO possibly being connected to a driver's license at some point in the future. Is that moving forward, or is that in the foreseeable future, or what are your thoughts
So
on that?
that is a great question. So in January, I guess enacted into law in the state of Maryland is that if you have a advanced directive, that it would be linked to your driver's license through some sort of link. We believe it's going to be a QR code. So preemptively for that, we are becoming preferred vendors in the state of Maryland for any advanced directive processes. In addition, we feel the MIDEO is ideally set, and that essentially is going to be an end-all be-all at some point in time for us to be on the driver's license of every client of ours, in addition to the insurance card of every client of ours, to make sure that it's available. Because the two things we know that show up in hospital systems are your driver's license and your insurance card. And no matter what emergency I've ever been involved in, we have people that find that information. Probably one of a couple reasons that go behind it. One is that we need that information to put you into electronic records. And two, I can tell you hospital systems want to bill you. So they're going to find your insurance card.
That's very true. Thank you. Next question, is emergency care on hold if a patient does not have their MIDEO card with them?
No, not at all. So so this is an interesting question in many respects. There was a time that if you had nothing, right, the default was provide all levels of aggressive care and treatment. And I'm glad to say that it still is the way today. But there is a group out there, and they're a group that focuses more towards the palliative side and the end of life side, that feels we really need to ask patients permission to treat them when they're critically ill. I'm not a believer in that at all, but there is a contingent out there that is trying to push that dynamic right now. But no, if your MIDEO card is not available, no one's going to withhold care and treatment on you.
Okay. And looks like last question for now. At one stage in life, one has multiple hospital venues and multiple specialists.
Mm-hmm.
Complexity?
I guess I'm not following the question.
Yeah, it says at one stage in life, I guess one may have multiple hospital venues and multiple specialists. I guess another way of putting it is there a way that could be a complex situation if people have multiple hospitals they go to or multiple specialists?
Yeah, and that's quite frankly where we find value too. You know, we have snowbirders, we have international travelers and so on, and that spend time, long periods of time in different states or different parts of the country. So, and again, we coordinate where we can coordinate, and what we found the value in that our patients feel very comforted traveling from here to, or Pennsylvania to Florida or Pennsylvania to Arizona, knowing they have something, especially at this time of post-COVID because of all the craziness that's happened inside the medical systems across the country.
Very good. Okay. All right. Well, thank you everybody for being here today. Thanks for your questions. Dr. Mirarchi, always great to see you. And let's do this again. Have some other ideas for some follow-up presentations, and we'll catch up. So thank you very much. I appreciate your time today.
Thank you, and thank you everybody.
All right. Thanks for being part of the Elville webinar series, everybody. We'll see you again soon. Have a great day.